welcome back to Dry Needling 360. This is the fourth episode, and the topic today is dry needling for analgesia. Before we begin the session, I would like to outline a little about what is dry needling 360. Dry needling 360 is one of its kind course, and we have tried to incorporate various facets of dry needling, and we have clubbed them into 6 different capsules in 6 different sessions. Today, as we have discussed, is the fourth session where we are discussing the cure for pain is in the pain, that is dry needling for analgesia. How do you take this free online course? You go through the study material tailored for the session. After you go through that pre-reading material, you attend the lectures on YouTube. Then you attend the quiz in the given link. Once you have attempted the quiz, you are eligible to download the certificate for the session. And once you have collected all 6 certificates, you are eligible to take one more larger MCQ and probably a little more tough, and then you will be issued a course completion certificate. The cure for pain is in the pain, which is a quote from Jalaluddin Rumi. But here, the first pain is what bothers the patient, and the second pain is the pain that you are inducing with the needle. How pain can cure pain? To understand that, let us understand our definition of pain. Now, as the medical science has progressed, our understanding and our impression on pain has also changed. So, it is almost more than 40 years old definition now. IASP had defined pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. However, last year in 2020, IASP has revised the pain definition, and they have introduced this highlighted segment resembling that associated with, which kind of emphasizes that even if there is no organ damage, tissue damage, or not enough tissue damage, if the patient feels that kind of sensation, then it will be considered as pain. That means the pain, the individual experience of pain had been given a greater importance or emphasis. They have also come up with a few notes accompanying the new definition. Now, these are not the original verbatim notes. I have kind of simplified them. I may have missed certain important emphasis in the process, but this is the most of the whole of it, that pain is a personal experience, pain is beyond sensory or neural activity, subjective experience of pain should be respected, pain affects function, and inability to express does not mean that pain is not being felt. I think vegetarians and vegans will have a field day with this. Inability to express does not mean that pain is not being felt. However, in its essence, the pain has not changed. We can play around with the words, we can change the definitions, we can create altogether new definition, or we can call pain in any other name. Teenagers will call pain as heartache probably. But in essence, pain is painful. Pain was painful when we were cavemen, when the prehistoric animals were attacking us, or we were attacking the prehistoric animals. And pain was painful even when in today's era, I know this movie is not from today's era, it's from my era, when Apollo Creed hits Rocky, the pain remains same. So essentially, pain is pain. Now, why do we need pain? We all know that pain is a protective sensation. Even today, if you go to the villages, kind of places where I grew up, when we used to have those kerosene lamps, when there is a small kid in the home, we will take their finger very close to the kerosene lamp so that they understand that the lamp is hot. And next time, even when the kerosene lamp is not burning, they will not go close to the kerosene lamp. So that creates some kind of protective sensation, a protective feeling. We understand what can damage us, what can affect us, and we try to refrain from it. In psychology, you get a whole behavioral principle called pleasure and pain principle. Wherever there is pain, you tend to avoid it. Wherever there is pleasure, you tend to seek it. So pain protects us. Otherwise, we would go and we would burn our hands and we'll make kebabs out of it. In fact, if you see someone with an anesthetic limb, that is why the wounds get so infected and wounds get so big easily, because they don't have any sensation of pain, and they will without knowing that there is an injury, they will keep on using that limb, only one fine morning to find out that they have this big a wound in the, if it is in the feet, in the back of the heel. So pain is protective, and pain is not the property of human beings only. Any higher animal will have pain. Take this example. The lion is scratching the zebra. The zebra needs to understand that it is harmful, and that is why the pain is there for him, and that is why he reacts, and that is why he runs to protect himself, and that is how the purpose of pain is solved. And that is why you have, say, the fast pain, because the lion does not give the zebra time. The zebra needs to the zebra needs to run very fast, otherwise he will be the lunch of the lion, and whatever remains will be the dinner of the hyenas. So that is why we have the fast pain, and that is why the sensations of fast pain is very, the receptors of the fast pain is abundant in the exterior of the body. They are exoreceptors. They are mostly on the surface, because the attack of the lion will come from the outside, not from the inside. Now, if you have studied a little bit of pain in your curriculum, you also know that we have another type of pain called slow pain. Now, we have already established that what is the need of the fast pain. The fast pain helps us to protect. The fast pain protects the zebra. When the lion scratches him, he needs to react immediately, and that is why you have the fast pain. Or it is not exclusive to zebra. You go to a friend's house, friend has a dog, the dog scratches you, you need to run immediately. But why do we have the slow pain? Body to tell us that we are not at our best. Our physical ability is not at its optimum. Imagine if this poor zebra survives, then the lion is poor actually. The lion goes unfed. But if this poor zebra survives, he will still have a scratch in his body. He will still have an injury in his body. Now, with this injury, it is not safe for him to go out grazing tomorrow, because tomorrow he becomes more vulnerable. Tomorrow he becomes an easy target. And that is the purpose of our slow pain, to tell us, to inform us about the interior of the body. So next day the zebra will not go looking for food. He will probably fast, or he will probably search something nearby in a safe area. Imagine the zebra does not go for grazing, but the lion comes and finds him. Now, if he still is in the spell of the pain, unable to perform, unable to run because he is having pain, then he will wash his hands out of his life. So the body needs to have a mechanism in place where, in terms of necessity, the pain, the slow pain, can be subsided. Because that time, now, if I get injury, I have a host of opioid and non-opioid analgesics, and as a physiotherapist, another whole new arsenal of modalities to reduce my pain. But whether the zebra or this poor animal who is being attacked, who is already in pain, they do not have that advantage of popping a pill. So for them, the nature had actually created a very strong analgesic system. Look at this animal. His leg is being completely captured by the crocodile, and still he has so much of strength that he can pull the crocodile, the heavy big crocodile, towards the shore. Now if this picture disturbs you, this gif disturbs you, you understand that there is a happy ending. You can go in the YouTube and you can search hippos come after this, and they kind of drive the croco away, and this animal survives. However, there is this mechanism which helps him to combat with the pain, and that is not exclusive to that animal. We all have this mechanism. Again, this is about 20 years old, when we were a little more younger. I don't know how many of you will remember this day. However, it was a big moment for the whole nation, whole subcontinent maybe. So this cricketer Anil Kumble had played with a completely fractured mandible, and he helped India fare fantastically. But he's not the only person. You will see a lot of sports person who can withstand the pain and who can perform. Not only sports person, more importantly, the soldiers who fight, people who fight, people who are at a heightened state of mind, sometimes religious fanatics in certain ceremonies, in many of the religions, they can hurt themselves or other people, and the hurt does not feel, because they are able to access, they are able to channelize that system where they can be immune to pain, or they can handle their pain in a specific way. And that is the way that we are going to use when we are modulating pain using dry needling. So to understand how this happens and to understand how dry needling does it, we must understand the pain pathway. We all must have studied this in some part of our curriculum, BPT. This is Clayton's electrotherapy, 9th edition, somewhere on page number 80 or little up or down. So many times we have to study this. And this gives us a more or less proper basic understanding of the pain pathway, how the pain fibers come and pain fibers kind of make synapses in the spinal cord, and then the second set of fibers, the second order neurons go to the thalamus, and then the thalamocortical fibers ultimately go to the sensory primary somatosensory cortex. However, this picture has one basic, I wouldn't say drawback, something like an oversimplification, where they have not differentiated between fast pain and slow pain. As we know, A delta pain is fast pain because it is myelinated, C pain is slow pain because it is non-myelinated. A delta pain has its fibers, like its receptors are more on the surface, and as we discussed, slow pain, C pain, its receptors are more on the interior, and that is why A delta, which is very pinpointed localizable pain, and that is why injury, when you get on the surface, you can actually say that this is the point where I have injury. On the other hand, when you have abdominal pain or headache, it's very difficult to pinpoint if the pain is coming from 2 inch above my ear or 3 inch below the eyeball, or abdomen at exactly, you can probably say that this is the quadrant of my abdomen where the pain is more, but beyond that, pinpoint localization is very difficult. On the other hand, A delta is very properly localized, and A delta is sharp pain. Now if you see the pain pathway, this is the basic pain pathway. You have an A delta pain system and the C pain system. Both are parts of lateral spinothalamic tract. However, if you go a little deep, one is a part of paleo-spinothalamic tract and another is a part of neo-spinothalamic tract. But let us not go into that much of neuroanatomy. What we need to understand is A delta, why it is fast pain. One of the reasons is it is myelinated. The second reason is A delta does not have any stop. It is a non-stop express train. So the primary A delta fibers come to the spinal cord, comes to the marginal cells in the spinal cord, and then the spinothalamic tract directly goes into ventral posterolateral nucleus of thalamus. There is no stop in between. It's non-stop. On the other hand, the C pain is like a local train where it has got multiple stop, like a bus. So C pain comes and gets like the handover happens from the C fibers to the substantia gelatinosa of Rolando, then wide dynamic range of neurons, then via the multisynaptic system it goes to reticular formation area, a diffuse area of network of neurons in the brainstem, and then it goes to again thalamus, from thalamus to cortex. But then because there are so many stops in between, they are the places where the pain can be kicked out, and also it is slow pain. So now if we have gone through and familiarized ourselves with this picture, in the same picture I will add some more connections, some more neurons. So the basic picture remains same, but you can see there are some more neurons, some more connections. And that is how the pain modulation happens. Now understand this, when the pain needs to be modulated, when the zebra is reattacked, when you have a second set of or a new pain which is a A delta kind. Whether the zebra has one more scratch or the zebra runs away and because of the process of running he hurts himself. When the cricketer starts to play or the soldier starts to play, injures himself, and that pain from the new sharp injury or because of you have disturbed the homeostasis of that injury, new pain comes. That new pain is necessary to produce the pain modulation. But as you can see, the final destination of pain is in the cortex, especially the anterior cortex. A lot of it also can be summoned by will. A lot of pain modulation can be summoned by will, and that is why the state of mind is important. And that is why if you are in a heightened state of mind, you will not feel any pain, or at least the intensity of pain will be felt later. Many times what happens, you start to play, you get injured, but you kind of are able to ignore, and then next day or in the evening you had it. Then only you realize that I have injured myself, I have overstrained myself in certain way. Now coming to the segmental modulation, so there are multiple mechanisms, okay, and the first mechanism we are going to talk about is segmental modulation. So this happens in the same segment, as in if I have pain in my, say, shoulder, where the C5 is the segment, then the A delta stimulation should be in the C5 segment only. And as you can see with this round, this thing, that once A delta is stimulated, in this case via the dry needle, yes, you feel the sharpness of the pain which goes through the fast pain pathway, but there is also a collateral, the green fiber here, which goes and stimulates the stopped cells in the spinal segment. And these stopped cell, ST cells, are the reservoir of enkephalin. And as we know, enkephalin is a powerful painkiller, is an opioid analgesic, and it stimulates this, it inhibits the SGR, the substantia gelatinosa of Rolando. So the transmission of pain via substantia gelatinosa to wide dynamic range of neurons to multisynaptic to reticular formation, everything is stopped. It's like the slow pain was trying to ride the elevator, and now the A deltas A delta's stimulation has gone to the powerhouse and stopped the power. So now the C pen cannot, even if it is in the elevator in the substantia gelatinosa, it cannot go higher up. So that is the segmental modulation, but that is not the only way how you can modulate or reduce the pain. The next system is serotonergic system, where one more collateral, if you come here you'll be able to see, again this is a topographic diagram. This is not actually how the connections are in the area in the brain, but this is a loosely made diagram, and I'm not a great topology, so this is the best that I could come up with. So you can see that one more collateral goes to periaqueductal gray matter of midbrain from A delta system from fast pain, and then from there the nucleus raphe magnus of medulla is stimulated, and that releases serotonin, and that serotonin again in turn stimulates the stop cell release enkephalin stops substantia gelatinosa, and the C pen is trapped inside the elevator. The C pen cannot go to the thalamus and cortex. But this is not where the story ends. You can see some more connection. So there is one more collateral which goes via the nucleus paragigantocellularis of medulla. If you are searching, it is here. Then it goes via the locus coeruleus of pons. Pons releases noradrenaline. Noradrenaline directly blocks or inhibits the substantia gelatinosa. So understand this. The first two mechanisms we discussed was related to opioid. In both the cases, the final neurotransmitter was enkephalin, which blocked the substantia gelatinosa. But in this case, it is noradrenaline. Also understand this. Both enkephalin, noradrenaline, or serotonin, all three are also the neurotransmitters that change mood. So in certain state of mind, these neurotransmitters are already there in the system, and that is why your pain will be lesser. For example, if you are excited, you are under the spell of sympathetic nervous system, the noradrenaline is flowing to some extent in your nervous system, and that is why your pain is less. You must have, if you have gone into a physical fight with someone, you will remember that when you were punched, the pain didn't feel anything, but in the evening or later on, depending upon the extent of the punch, probably you are holding an ice pack. But then one more system, right? This heading is wrong. Okay, this is called as DNIC, diffused noxious inhibitory control, where the reticularis dorsalis directly can inhibit the substantia gelatinosa. Sorry, I have copy pasted the heading, and the heading should read as DNIC, diffused noxious inhibitory control. Now, so once you understand that these are the mechanisms, you should be asking about the dosage, how many needles, how long to keep, where to put, and all this. Now that is a separate topic of discussion, and a lot of it has to be learned hands-on. But the amount of stimulation that you give, or amount of stimulation that is necessary to produce enough analgesia, is dependent upon the type of responder that your patient is. Now, what are the types of responders? Loosely speaking, multiple people respond differently to the needle induced stimulation. There are certain people who respond immediately, and they can be called as strong responder. On the other hand, there are other people who respond very slow, and they are called as weak responder. On the other hand, rest of us who are in between are average responders, So for a strong responder, you keep the needle only for a short amount of time. You insert the needle, probably keep it for 30 seconds to 1 minute, pick it up, the patient will get analgesia. Strong responders are about 10% of the whole population. There are also the like textbooks will say that the strong responders are probably young individuals, uh, Caucasians, and light colored eye, light colored hair if you have hair, uh, little children, hypersensitive people, people who have a very low pain threshold. If they just give the pinch and they'll say they're strong responder. Opposite of this is weak responder. But then again, it is very difficult to identify looking at the characteristics. And if you over needle, then what tends to happen is the pain may increase, and which is called as opioid induced hyperalgesia. It's a real thing. Again, all these things I'm not making it up. You can go, you can check on the net, you can find out on the textbooks and research articles. For example, opioid induced hyperalgesia happens in people who are taking too much of opioid. For example, terminally ill cancer patients, too much of opioid will produce increased pain for them. You may ask how this is possible. You may ask that where is the science behind this? You and I both will take 500 milligram of paracetamol for our fever. Then why you need more stimulation from needle, and why do I need less stimulation from the needle? The reason is because probably for opioids, the concentration and the numbers of receptors are different. And someone who has high number of receptors or high concentration of receptors in specific body part will need a little lesser stimulation. On the other hand, someone who has a lower number of receptors will probably need a higher stimulation. There will be a weak responder. Can I give the analogy of people who can withstand? There are people who can withstand the whole bottle of whiskey and they will still stand on their two legs and they will walk the tandem walking test. Then I have friends who gets high even with the smell of the alcohol. So there are actually difference in the population based upon how they respond to opioids or other kind of intoxications. However, if you are unable to produce enough A delta stimulation to produce analgesia, what are your ways? You understand that you can supplement the stimulation of A delta via needle. There are a few ways. So basically our aim is to stimulate the nociceptors, and as we know how the nociceptors are stimulated, they are stimulated only in three ways. There are only three ways to stimulate a nociceptor: one mechanical stimulation, one thermal stimulation, one chemical stimulation. So what is the mechanical stimulation? The pinprick sensation itself is a mechanical stimulation. Thermal stimulation, yes, you can heat up the area where you have inserted the needle. If you are thinking of traditional Chinese medicine, acupuncture, sometimes the burning of the moksha on the needle head can do the trick. As a physiotherapist, in a controlled way, you can use infrared radiation. There had been use of it if you think that your patient is not benefiting only with the needle. But then other way of heightening the nociception, of course you are not using any chemical. Other way of heightening the mechanical stimulation is to play around with the needle. As we had said, we have seen the needle has a guide tube, and once you put the guide tube on the patient's body and you tap, the sensation of the guide tube is compression, that is A beta sensation. It takes away the A delta a little bit, and that is why needling, the thought of needling is scary. But after you needle, you ask the patient says that the pain was not that much because the guide tube was kind of giving the patient shield from the pain. But in certain cases, probably you want a little bit of pain to be felt. Sometimes you poke the needle so much that the patient has that sharp indrawing of the breath, and that sensation you want, because that would be an affirmation that you have stimulated the A delta enough. So sometimes what you do is you don't use the guide tube. You take the needle, remove the guide tube, and insert the needle directly. If you are looking for an extra amount of A delta stimulation, or if you are angry with the patient, you want to give the patient a little bit of pain. Okay, this is simple joking. This would be unethical if you practice. Okay, so your therapeutic aim is to give a little more A delta stimulation. But if what is also another way is to incorporate one more pathway, and that is attaching needle with TENS, which is called as percutaneous electrical nerve stimulation. So it's just, instead of transcutaneous, you are giving percutaneous, which is basically combination of TENS with the needle. You are transmitting TENS with a needle electrode. Now, how is this going to work? The same picture, if you remember. Now this is a mechanical stimulation, and the sensation of TENS is going to go through the dorsal column. If you remember, the posterior column, cuneatus gracilis, tractus cuneatus, tractus gracilis, and then it stimulates the periaqueductal gray matter, again works on the nucleus magnus, releases serotonin, releases enkephalin, the substantia gelatinosa. Along with that, one more afferent comes to substantia gelatinosa and releases one very important neurochemical called GABA. And we all have seen how patients behave with GABA. Like, GABA is one of the most potent pharmacological agent when you are coming for pain. So if you apply needle as well as TENS simultaneously, you are adding one more neurotransmitter in the cocktail, GABA. You must have seen a lot of prescriptions where the patients were prescribed either gabapentin or pregabalin. Sometimes the problem with GABA is GABA produces certain other side effects, as in GI irritation. So this GABA you are delivering at the site of the pain, at the segment. Now I must owe my gratitude to these two people. The first person here is David Bauscher. He was the person who had described the needle-induced analgesia, and this diagram is drawn by him. I found this diagram a little more daunting, so I have made my own set of diagrams, but this is the original diagram. And the lady here is named Candace Pert, and she was the person who had discovered the opioid receptors in the nervous system, and that actually had opened a lot of understanding and discussion related to the connections of the nervous system, how nervous system is not only a landline where the physical connection to the neurons are necessary, but it is also like a mobile where anywhere there is a circulation, there is a signal. So basically, that is why these two people should be remembered when we are talking about anything to do with either pain or neuropeptides like enkephalin, endorphin. Now, what are the parameters when you are using percutaneous electrical nerve stimulation? You can play around a lot, but basically research support says that if you keep the frequency between 2 to 4 hertz, so basically what we know it as a low TENS, there happens release of endorphin and enkephalins, so all opioids. However, so this is for taking away the C pain. However, if you are having a pain which is A delta pain, a sharp pain. Now when we had a slow pain, we could have avoided the slow pain by stimulating with a fast pain. If I'm having, say, neuralgia, I'm having a fast pain. Is there any way to take away the fast pain? Yes, with PENS, you can keep the frequency on the higher side. Then you will release, of course, GABA, but also dynorphin and galanin. Now, dynorphin and galanin merits further explanation. If you break down the name dynorphin, you will definitely understand that it is a morphine agonist. But the difference between dynorphin and morphine is dynorphin is 10 times more potent than morphine. So it's a very strong painkiller, stronger than morphine. And then galanin is also interesting. If you see galanin, the response to pain is modulated via galanin. So if I have to simplify, I would say that if I have less galanin and you have more galanin, and you get hit by a punch and I also get hit by a punch, you would be able to withstand that punch very well. I will be feeling more devastated with that punch or injury. And that difference of how we behave or what is our response to the pain is function of galanin. Of course, a simplified explanation. Now, how long do you want to keep the needle, or how long the how long do you want to keep the needle will be based upon the type of responder. But here I would like to discuss what is the duration of needle produced analgesia. This merits a discussion because when the patient comes to you, the patient wants something, and if the patient is coming for pain, of course the physiotherapist's role is not only to treat pain, and dry needling is also not an exclusively pain modality. Dry needling can do a lot of other things, but if you have decided to needle for pain, then you should be giving the patient something more than a 2 rupees paracetamol or a 10 rupees a stronger analgesic will do, right? So if I take a paracetamol of say 650 milligram, I get 6 to 8 hours of guaranteed analgesia. Yes, I have other side effects, and I have other problems, and there is no other benefit of paracetamol, but the patient has to have this cost benefit analysis. So how long does the needle induced analgesia persist? Understand this, your duration of the needle, even if it is for 5-10 minutes, if you remove the needle, that does not mean that your effect of the needle is finished. Why? Because once you have inserted the needle into the body, once you take it out, you have created a small microscopic well in the patient's skin, patient's exterior, and that small wound will stay for some time. And as long as the wound stays, the A delta stimulation keeps on happening. Remember, the nociceptors are very poor receptors when it comes to accommodation. You know, globular tap, right? If you tap for some times, there will be accommodation. If you wear a tight trouser, initial few times it is so uncomfortable. After that, you go out, you forget about that because the body accommodates. But if you have a throbbing headache, if you have an open wound, your body will not accommodate. Wherever you go, whatever you eat, whoever you be with, the pain will keep on knocking you. So what is the duration of this analgesia? As long as the A delta is getting stimulated. And how long is the A delta getting stimulated? The A delta gets stimulated as long as the wound is there, which is between 1 to 3 days. Now it will depend upon how long is the, say, what is the depth of the needle that you have used, what is the depth of the target tissue, also the healing rate of the patient, where you have needled, what are the techniques, what are the manipulations you've used. But basically, to give you a range, it is between 1 to 3 days. So a needle induced analgesia may remain for 3 days. And that's why dry needling is so successful, because if you have a condition which gets resolved automatically within that 3 days, the patient may think that the needle alone has cured my condition. On the other hand, what the needle has done is the needle has probably taken away only the pain. Of course, again, there are other mechanisms how needle will help, but then that will also mean that you have targeted some other functions as well. So the needle induced analgesia is very strong because the the painkillers reduced the painkillers released by the body by needle stimulation is much more stronger than the painkillers we ingest, and because it happens naturally within the body, there is very little side effect in terms of the released chemical. Of course, we have talked about the dangers of the dry needling. So that is why needle is so successful. Add to that, because it is a novel kind of modality, the patients kind of a lot of patients want to brag about their own kind of treatment, the speciality of the treatment that their their healthcare providers have given. So that adds to the charm of the needling. But otherwise also needle is a potent analgesic. Now, how do you do it? Obviously, you'll have to assess, and I'm posting this picture once again. Day after tomorrow, I'm going to discuss this, how you assess, how you rule out other conditions, what are the contraindications you need to look at, how do you manage them, what is the process, and finally, a word of caution. As you can see, there are two case studies where one person with needle induced has got needle induced pneumothorax, and another person had got permanent wrist drop because of dry needling on the radial nerve. So if you are needling your patient, please be careful, please take proper training under supervision, hands on, by a qualified needler, by someone who has done it and who regularly teaches it, not necessarily by me, but you have to learn needling from an expert. So with that word of caution, also understand that our pain as well as the human body is like this iceberg. So whatever information I'm giving you or whatever information I hold is also the tip of the iceberg. You need to learn much more in detail. You need to develop a lot of skills before you go and needle uh, your patients or whoever it is. With that, I'll finish the session today. Let's see if there is any discussion. Okay, let me go back to the discussion pen. All right, where can I get pens machine and how to use it, sir? I mean, what's the procedure? It takes a little more time to explain. Whatever I'm giving you here is kind of a capsule. It merits a lot more discussion. Indications and contraindications of PENS machine. कंचन शर्मा पेन्स नहीं टेंस होता है व्हेन यू गिव अप, जब नीडल से लगा देते हैं तो वही वही टेंस पेंस हो जाता है. यस, विशाखा, करेक्ट, वेल सेड, राइट. सो if the painkiller is good for is if the painkiller is good for our body, anything you take up from outside is not good. A pharmacological agent in general in the long term is not good. Anything in overdose is not good. Fantastic, Rizwan. Well said. Uh, all right. Contraindications of pens are more or less same with the contraindications of dry needling. How many sittings we need to give for periarthritis depends upon the stage. Depends upon the patient's condition. Periarthritis, in certain periarthritis cases, they will come to you. You'll mobilize. You'll in one sitting you produce astonishing results. Sometimes you get astonished yourself. And in certain other set of patients, whatever you do, you use all of your expertise, all of your skill and knowledge, and then also the patients do not improve. So periarthritis is a little tricky condition. Understand this. If you are in terms of what we are using today, we are talking about analgesia. So analgesia, you can give the patient a significant amount of analgesia, any patient, using dry needling in a single sitting. How many times can give needle analgesia in a day? Very important question. How many times you can needle a patient? In the same point, if you are needling, you needle today, the wound will remain. So there is no point to needle the patient on the second time, unless I am a greedy physiotherapist and I want to charge the patient for 2 sessions in a day. I wouldn't be needling the patient in the same day twice. I usually wouldn't needle the patient in the same area in the next day as well, unless it is a special consideration. Sandipan, 2 to 4 hertz when you are treating a C pain, a slow pain, and 80 to 100 hertz when you're treating a fast pain. Dr. Vishnu, good afternoon, Dr. Vishnu. Some using dry needling with stimulation in Bell's palsy. Is it safe to give on nerve trunk? Nerve trunk dry needling with electrical stimulation. I have come across articles. So there, it is not like there is no research support. But again, if you are looking at electrical stimulation for Bell's palsy, we understand that it is an adjunct, right? The research says, and I'm not the neuro guy, but more importantly, I understand that with Bell's palsy, your primary area of work is again exercise and specific neurological interventions. After dry needling, need to give ice or heat to the patients, or need to give any other modality? Fantastic, great question, Dr. Vic. After dry needling, now if you are using any gel-based modality, imagine, then that wound is there. You don't want to meddle with that structure, so you don't want to apply any contact modality, whether it is gel-based ultrasound or gel-based IFT on that area, TENS, IFT, anything. So on the other hand, needle is just another way to, as we had discussed yesterday, modulate the myofascia. So right after DTFM, we have the convention of applying ice. You can apply ice after needling. Okay, so many questions are coming. What we can do is, probably one day for each group we can have a Zoom session where we can take individual questions, we can interact face to face. If that works, then it will be fine. I think because I have so many groups for this particular DN360, we'll have to have multiple Zoom sessions, but we can I think manage it. Smarika, seen some therapists needle and wait for 15 minutes. Can you explain this much of time is required, and when they pick out the needle, they kind of poke in and out the needle few more times? Yes. So the poking in and out of the needle is called as pistoning. We'll discuss this in much more detail tomorrow. So if this is the needle, you are poking in and out of the area which is called as pistoning. 15 minutes, yes, 15 minutes. Again, if you go to article research support, you can see that people have kept needle. Some people have kept needle for lesser time. On the other hand, other people have kept the needle even for half an hour or more. So there are research evidence for it. However, not all patients will need 15 minutes of needle. Okay. A lot of people are asking about periarthritis frozen shoulder continuum. We will probably, that would really need a hands-on session, how many needles are, but understand this, subscapularis is one muscle that and the teres major, that if you can needle, gives good result in many of the cases. How to decide how many needles are needed for a specific condition? There are a few more thumb rules. But then again, you will have to judge it based upon the patient's condition. But then, say Dr. Yuntao Ma says 2 to 3 needles for 1 square centimeter area. On the other hand, when we talk about needle rotation, tomorrow we'll see that once you insert the needle and rotate, the effect of needling rotation goes up to 5 centimeter. So you can use, one convention is about say 5 centimeter gap if you are trying to change the myofascial modulation. If you are trying to impart needle induced say analgesia, then you want to give more and more A delta stimulation if the patient's A delta is not enough. So in that case, you can do either a temporal summation, as Smarika has typed, that more than 15 minutes or easy if you are increasing the amount of duration, or you can increase the amount of stimulation keeping multiple needles. Depends upon the patient, depends upon the patient's condition. Yeah, Zoom probably we finish the 6th session, and after that, but again, we'll have to see the feasibility and we'll do it. Frozen shoulder again, yes, Dr. Vishnu, thank you so much. Just treat using needle. We can treat gynecological pain. Gynecological pain is such a big umbrella. It's more than an umbrella. It's a dome. It's kind of a planetarium kind of thing. So in certain cases, yes. In other cases, not. Okay. Muhammad Sadiq, maybe we'll have something else then, wherever you are there in your group, whatever is there, probably Google Meet for your group. Okay, Meet, fantastic. But again, I cannot keep on doing the Zoom sessions. Probably 1 or 2 Zoom sessions we'll try to discuss and we'll finish. Or we can keep one in a week maybe, if lockdown continues. Stretching necessary after dry needling? Yes, stretching is necessary after dry needling. And good that you have asked Pramod. I will discuss this tomorrow. Dr. Meena, thank you so much. Motor points of back muscles for dry needle. Okay, motor points and trigger points, or the needle, or the area of target tissue of needle are different. Sandeepan, please understand this. Again, to describe the specific structures to be needled is not in the scope of this specific set of course or DN360. So after this, I think thanks are, yes, stretching is necessary, Pramod. Only thanks are coming, I guess. Still our tapping session. Let me finish this. Then we'll see again if lockdown continues. I don't know what to do with my time, so I'll probably continue doing this to some extent. Let's see. After dry needling, yes, we can use cold. Stretching exercise after dry needling is beneficial. Aishik, you can treat spasticity with dry needle. Again, the explanation is very difficult to give in verbal thing. Read up DNHS by Pablo Herrero. I have every day I'm talking about this, and I wonder why everyone is concerned about spasticity. Kaushik Pal, if you think I'm good enough, I can teach you dry needling. There are so many other good instructors. We have a pack of dry needling instructors, so you are welcome to choose many of us or any of us. From where we shall get the pens machine? I don't really want to endorse anybody right now. Dig around in the internet, you'll get it. Thank you. So without extending the session too much, Ritika, Harish, without any fees, right? I think even if money was not a consideration, I would have tried to give some kind of merit, and that's how you should rate this class or course. Not because it is a free session, but because you probably have gained something. But thank you for the appreciation. Fracture patients, again, what is your purpose? The pens itself will not treat fracture. Passive movement after dry needling, yes, you can, but if the patient is able to perform active movement, functional movement, then I will probably go into active movement, active assisted, if functional movement if possible. Passive movement otherwise is so 90s therapy, no? Jayashree, if you want to learn hands-on dry needling, music to my ears, come to me, I can teach you. As well as there are so many other excellent instructors within and outside India. You are free to choose anybody. Krishna Kali, in Kolkata, I had a workshop scheduled in 1, 2, 3, 4 April, and then you know what happened in April, and then you know what happens in May. So kind of stalled, but yes, keep an eye on the WhatsApp groups. I will probably uh, give you the updates. Thank you, Dr. Thompson. Thank you so much. I'll finish it here. Thank you, everybody. See you tomorrow. And tomorrow we are going to talk about needle manipulation, which is very important, which is very interesting. With a simple tool of needle, what are the things? What are the things that you are able to perform? So with that, goodbye for the day. See you tomorrow. Thank you.